Nothing on the Bonnell Foundation's Living with Cystic Fibrosis podcast should be considered medical advice. Medical advice can only come from your CF physician. Cystic fibrosis can be a devastating diagnosis, but living with the disease can bring positivity and a new appreciation for each day. From the Bonnell Foundation in Detroit, Michigan, it's the Living with Cystic Fibrosis podcast, sponsored by Viatris, Genentech, and Vertex. Here's your host, Laura Bonnell.
In January, the American Thoracic Society did a presentation via Zoom about the challenges facing CF families in low-income countries. There were many incredible doctors and scientists included, many who you have heard from on this podcast. But this was the first time I became aware of Dr. Hector Gutierrez. Dr. Gutierrez is the Raymond K. Lyrene Chair. He is professor and director of the Division of Pediatric, Pulmonary, and Sleep Medicine at the University of Alabama at Birmingham. Dr. Gutierrez is native to Chile, where he did medical school and pediatric residency. He did his subspecialty training at Peds Pulmonary UAB and has been at the CF Center since 2003. Dr. Gutierrez has developed a robust training program for CF teams from resource-limited regions outside the United States. He is currently the co-chair of the CF Foundation's Global Advisory Committee, and we are honored to have him join us today. So welcome, Dr. Hector Gutierrez. Please start by telling us about the work that you're doing and the training program that you have outside of the United States.
Well, thank you for inviting me to the podcast. The work that we have been doing as a CF Center, I have been a CF Center director for close to 20 years, training the knowledge, the ability to work well within a team in CF care was kind of a standard issue in the U.S., but it's not a standard outside the U.S. So we took the opportunity several years ago, 2014, to begin to see if international teams from a low-resource country were able to learn the same way that we have done it. And we have been very successful in doing that. We are in our year 8 or so, and we have expanded to just one center in a country in Chile, in South America, to several countries now.
And Chile is your native country.
That's correct.
So very dear to your heart, I'm sure. What have you noticed there since you started this program 8 years ago?
Okay, so there has been a significant progress that was affected by the pandemic that affected the whole world. So the resources, the priorities switched completely in early 2020. So there had been a delay in progress, but not a stall. What we have seen is a better appreciation of teamwork. The structure of delivering care in Chile and in most of Latin America is very depending on the leadership of the doctor. So it's very pyramidal, if you will, more than a teamwork where you have some quote equals that can lead and can help do the work better. That has changed, and that has led to improving outcomes and certainly improving processes. The way that the care is delivered is more efficient in those centers who have taken the lead in working in a multidisciplinary fashion.
And there are so many important things to learn. I mean, it's only over the past couple years since Dr. Samya Nasr raised awareness with me about the challenges and underdiagnosis of people in Egypt, and then people of color here in the United States, including the Hispanic community, that are underdiagnosed. You're doing so much, but wouldn't you agree that the actual number of people diagnosed today is extremely low because several communities aren't even being counted yet because they're just at the beginning?
Yes, it remains a challenge for finding what, where, and who are those patients that are being missed. However, we know the ones that are already diagnosed. And although it's important to find the ones that have not been found, we already need to work with the ones that are present. And that goes to the tune of the thousands in South America. The expectation of having how many patients we see in Latin America from Mexico down is more than 30,000 patients, just based on, genetics. It was one patient with CF in the Hispanic community in the US. So it's about 1 in 20,000, but there are 350 million people living in Latin America. That puts you in over 30,000 patients that are supposed to have CF, which is half of what we will see in the Caucasian population. Although again, being Hispanic, it doesn't tell what race you are. You might be Sammy Sosa from Dominican Republic, Black, or Giselle Bunsen from Brazil, who is completely Caucasian, but both are Hispanic by definition of the region. It's a contraction, but nonetheless, the complicating factor is we need to treat the patients who are already present and find the patients who are not being diagnosed. And that's a challenge. And I have the fortune to share with Dr. Nasr the methodology that we have done in South America. She did it in Turkey and very effectively as well.
So many great organizations that you're working with and doctors and MECFA, the Middle East CF Association, doing fabulous work, a lot of it in Turkey. So those patients that you're helping, what are you hearing from those CF parents? I mean, they must be so many emotions, glad to finally have a diagnosis, sad, frustrated, don't have proper medication. What do you hear from your work on the ground there in Chile?
Okay, so there are several issues that makes caring for CF at the family level a challenge. There's an issue of access, and there are not too many centers or specialist healthcare personnel who can take care in the proper manner for CF. So lack of centers, lack of training by the doctors, lack of medications. And the newer medications are unaffordable to a large part of the world, not even just low and middle income countries. Very developed countries are also struggling to find the funds to get the CFTR modulators. So their families, the first thing that they see is how can they take the care in the day-to-day basis if they don't have a doctor that is well trained or doesn't have the knowledge or the medications are not present. Prioritizing what can be done is complicated. It's very hard for the families to understand that they need to have a better medical team that is trained in a multidisciplinary fashion if they don't have access to vitamins. That might not be depending on the medical team to have the vitamins or the enzymes. That depends on the government. And that's a whole different challenge. But still, what we have been able to tell the families and their teams, tell them as well, let's do what we can do without waiting for the vest or for the CFTR modulators, because that is completely out of our hands. And that is what has been most impactful. Making the team, the medical teams and the families working together, prioritizing what they can do at their level, because there's a lot of things that can be done at that level, not just waiting for the resources. I mean, COVID-19 vaccines were not available in many countries at the beginning. Chile was fortunate that they negotiated very early and they have one of the highest vaccination rates in the world at the beginning of the pandemic. But that's government put the priority there. But it's not a priority to CF. CF is not a priority in many countries of the world because it's a very, very rare condition compared to diabetes, asthma, and hypertension.
And that is such a great point. And that's one thing I saw. I relate to Egypt because that's where I went in person. And those parents were very upset they didn't have the vest. And I said, you can do percussions. Mm-hmm. I did percussions with my girls in the beginning, and they actually didn't like the vest. So it was kind of family time when you could do those chest percussions. So I agree with you. It seems like the grass is always greener somewhere else, right? America is not perfect. We have so many things we need to fix in regard to health insurance and all sorts of things. But I know it's hard when you're in a low-income country or a country that doesn't have access. We seem like the U.S. has it all. So when you don't have the basics like enzymes, where do you start? Like you said, you start with what you have But how can we change that? How can CF parents or the CF community help you get what you need? One thing Dr. Nasr taught me is you have to give the country what they need, not what we think they need, right?
Mm-hmm.
And it has to be sustainable, so we don't want to just keep sending donations. So how do we help?
So the basic medications, antibiotics, enzymes, vitamins, they were not easy to access or available 15 or so years ago. Now they're available. It might not be the different choices that we have in the US. You can change from enzyme brand 1 to brand 2 to brand 3. And that choice might be beneficial to some patients. Most of the patients would probably be fine with just one type of enzymes that you don't need to change. It might need to alter the dose, but not the brand or the type. So the families might be able to use only one brand because that's the one that the government has contracted with the provider, with the pharmaceutical company. And there might be a few families that medication, that particular patient might not work as well as brand B. So how do you improve access is by telling the governmental agencies, most of the time, it's a national program that controls the access to medication. You need to present the information, the data, partner with your medical team. And most of the countries do that. And those are the ones that the government need to hear. Now, in the country that we have been working, Latin America, most of the basic medication, not CFTR modulators, not the VEST, are available. The key is to use them in a manner that is more effective. And that is where the lack of education and the lack of understanding, misconceptions. We went through a significant degree of misconception with COVID-19. So misconceptions in the medical personnel and misconceptions in the family are real issues that will, by having those cleared, makes the care with the current medications, with the current resources better. And that is where there's a partnership between the families and the children, the patients, with their care providers. And then they might present information that the government, hopefully looking for their best of the patients, is able to make a change.
And I guess I'm also asking, and it's a pretty big question as far as, like, I want to talk to the World Health Organization. I want to say to them, how can you allow this? Like, from the big picture, would a CF group of parents help? Like, I guess I'm wondering on a global level, how can we help? Because we want to start an organization that says, okay, you've got all these different doctors all over working in their respective countries of interest trying to help, but how can we as a community help you get things done?
For medication access, lowering the barriers to the government or the health organization, ministries of health, be able to afford the medication. And this is not just for CF. I mean, it happens in African countries with malaria medication, tuberculosis medications, any other. Medication access is a real problem in most of the world. Well-developed countries in Europe didn't have CFTR modulators, but years later, because it's a very expensive medication. So what you could do here is to, again, call the pharma companies to be able to sell the products, make the products more affordable. That comes with a problem too. If we are paying $300,000 for a medication A, and that same company is selling the medication at half the cost, that is unfair to the U.S. as well. So how can you help, in my view, increase the awareness of the imbalance when medications that are life-saving, again, I will put the name, the word in vaccines. Those are necessary anywhere, everywhere. And by helping understand the people who is in charge of selling or putting a price or providing access is a way to go. Just trying to provide money or funds to a number of medications that will last for a few days or a few months is very helpful, but it's not sustainable. and also creates a problem with inequity. Some patients were able to receive that medication. Great for them. What about the others? And that's an issue that we see in the U.S. all the time as well. You mentioned different races of African Americans access to low income communities in the U.S. have different access. It's much harder for them to achieve or reach what we are able to provide.
I think the health is the most important thing in the world that we should all be working together on.
Mm-hmm.
It should be the number one. It's as disturbing as any war to me that it's so unfair because it depends where you live on and how much money you have, sort of what kind of care you're going to get. That's not a new problem, of course. It happens in the US and everywhere. But the other thing, someone from another drug company gave a great analogy. He was saying they had lowered prices and it cost the company millions of dollars, which we understand and we have to all work together and figure it out. But he also said what you pay to, he was giving an example of what you pay to paint a house is different in the United States than it might be in India. So prices are different. I mean, I'm simplifying it big time. So I hear what you're saying, and I think we do need to really work together to make this change. You know, you talked a little bit about the growth and the changes that you have seen in Chile, but tell me what you're hearing from parents who finally have a diagnosis.
Before answering that question, another thought that comes to mind is, how can you help? Was your question initially?
Please.
The organization of parents and families in the US and Canada are similar countries in presenting and supporting their medical teams is something that you could actually transfer that knowledge, that know-how, that approach to the families in other countries where they're just trying to organize and seeing the priorities change some in the way that you can help them there. If you go and ask them, the only thing that they will ask is for access or for medication access or for, able to be in the hospital when they need it. But there are other priorities that you can actually help them in organizing. And that is an area that is not being language barriers in between, is not being explored more effectively. Now to your question, repeat it again.
I will repeat it, but I wanted to make sure I understood what you're saying. Are you saying that we can help in the US and Canada medical teams with the language barrier kind of situation, or?
No, what I meant was to reach out to those families. There are family organizations the same way that they are in the US or in Canada.
Okay.
There are family organizations in Argentina, in Peru, in Chile, in Mexico, where they are trying to do the same thing that the US did 40 something years ago. And they can gain knowledge. They can learn a strategy to be more effective. And that is just the transferring of know-how from parents organizations in the US might be helpful for the parent organizations in low and middle income countries. That's what I meant.
And that is a great point, because I have learned, and again, I am years into this, but so new on this, where you and Dr. Nasr and Dr. Grace Paul and all these other wonderful physicians and scientists have been doing this work for years. So I thank you for that. But we are just now learning that parents or families don't have trust of the registry or feel like they're going to be tracked by their
Correct.
government. So we are learning things like that. So that is a great idea for us to get in touch with families who have started advisory committees or are just now banding together. That is a great idea. I love it. And have talked recently to a CF mom in India who had challenges because it's just, there's a lot of shame in having a chronic illness that I didn't realize in that country, just because it's a rare disease and they're still learning about it. So I think that's a really important point to talk to other parents, and something, again, that I learned in Egypt when talking to them, and we learned and shared so much. And I'll repeat that question again. I just wanted to hear what you learned from the newly diagnosed CF parents in Chile where you're working. and, having some progress, are they finally glad to have a diagnosis?
Yes, I think the sooner that the diagnosis is made, as it happened in the US when there was no newborn screening, the sooner that you get the diagnosis, the sooner that you can start to get treatment and preventive complications and the progress of the disease. In Chile or in Argentina, which was the two countries that we have worked most, the government's putting a newborn screening program, pilot in Chile, already established in Argentina, plus the work of the medical teams in working quicker, decreasing the time from the testing or the suspicion to confirmation. That leads to a great relief. And then the families who are being diagnosed with their new baby are entering into a program, into a system that is better equipped for them. So in that way, you have a period of stress and despair when you might have the diagnosis or the baby has symptoms, but they're not confirmed. That has decreased. And then when they enter the system, they enter into a system that is better prepared for them. A medical team that knows, and it's not just the doctor who knows. They have a lot of knowledge, but the way that they work is better for the parents as well. So that decreases the anxiety.
It's really like stepping back in time, is it not? Medically, stepping back in time, I guess, to where the United States was before we were diagnosing CF, and we've only been doing newborn screening for CF since 2007. So we're not that far ahead,
Alabama implemented it in 2008. So
Wow.
Not all the states were in with newborn screening. Now it's universal in the US. But in some European countries, newborn screening is not allowed.
Right. Yeah. It's very interesting. What did you witness as far as the families in Chile and Argentina? Did you find that you were diagnosing multiple siblings? Had parents lost siblings prior to understanding the disease?
No. Again, I think that Chile and Argentina have been fortunate with their medical care. The missing diagnosis was not as significant as in India. The awareness of CF as a potential diagnosis is more significant in countries like Chile, Argentina, or Brazil. It's less significant in countries like Asian countries or India. I mean, in China, nobody suspects CF until you need to suspect it. But in Scandinavia, if the patient having those symptoms by the nature of the ethnic admixture, then CF will be much higher in the ranking of potential diagnosis to rule out. So the awareness of those were there. Probably 20 years ago, we might see a 5 or 10 years old finally was diagnosed with CF, and he has chronic respiratory diseases. Now, it happened the same process at the US. I remember when I did my fellowship, we diagnosed a 35-year-old, tall and nourished patient with CF, but he was 35 years old. He missed the diagnosis. And then we realized that the patient had pneumonia infection when he was in an ICU, but never before. So the diagnosis were missed. That's what the purpose of newborn screening, to diagnose when you don't have any suspicion whatsoever. When you don't have that available, I think the time for diagnosis has decreased. The age of diagnosis has improved younger, so you can intervene more effectively. And that is happening in Chile and Argentina. They're missing diagnosis, but not as we were having 20 years ago.
What I'm hearing then is that it's really not diagnosis so much in Chile and Argentina and Brazil. It's the medications, the access to medications, like you had said.
Access to medications. And also, but again, from my medical perspective, I see it from the other side. We need to be prepared to care for a patient. If you have a complex surgical problem, you need to have a surgical team, not just the surgeon who does it. You need to have all what entails for that surgeon to be effective. You cannot repair a coronary artery in the ER. You need to do it in the OR. You can see patients with CF in your private practice, and you have the same knowledge, but you don't have the same equipment, the same expertise with you to care for that patient in CF. And that is a complicated mindset that you need to have with many families and different countries in Latin America, where the patients are being seen by a very capable professional, but in isolation. That is changing. There are CF centers, and that we're trying to do is strengthen the CF center so they can provide better care for their patients. And then as they become models of care, other medical teams copy them. It's in the same way that the US did it in the early 2000s with the learning, leadership collaborative, quality improvement. That wasn't a standard in the US. A seminal paper by the New Yorker in 2004, the bell curve that was, written by Atul Gawande, showed the difference in outcome in patients being seen by CF centers where in the US, and they still happen. We are not exactly the same outcome in the US. There are very many differences. We might have the same access to medication, but still there are teams that work better than others. It's like, the Miami Heat made it to the finals, but Austin Celtic were not.
Right. It's like anything.
There are better teams that are out.
Right. Great point. Absolutely. And what is the life expectancy for CF patients in Chile and Argentina?
It's much lower than the U.S. In the U.S., just in 2022, the 5-year range is now approaching 56 years, which is great. And this is related to the CFTR modulators. But before the CFTR modulators, the life expectancy or median survival that is called was approaching, mid-40s, while in Canada was approaching the mid-50s before the CFTR modulators. In Chile was approaching the 30 years. Now is about 30, and Argentina probably about that age or more. Argentina has CFTR modulators and that are made by Argentinian pharma companies.
That's interesting.
So one thing that we did in our conversations with the Chilean government, who really took it hard before the pandemic, improving access, improving training of the medical teams, creating a CF-centered network was very telling. The life expectancy of a girl born in Chile today is better than the life expectancy of a girl born in the U.S. today by more than 2 years.
Really? Just a normal, not normal, but a healthy...
The normal life expectancy in the Americas are 3 countries that are better than the U.S., clearly. Canada, Costa Rica, and Chile. Those 3 countries have longer life expectancy than the U.S. as a general population. And the life expectancy in CF in Chile is much, much, much lower. That is a contradiction in terms. That's a paradigm that we need to change. Why Chile, a boy or a girl born today, has a better life expectancy than an American born today, but it's not happening for CF? Might be resources, might be diet. Good wine from Chile helps too. But access to medications, complicated medications, and training is different. And that's where we need to close that gap.
Send over some wine next time you visit.
Yes. Yes.
That sounds delicious. Yeah, that is really interesting. I had no idea that the life expectancy just for someone born healthy is better in those countries than the United States.
Yes.
What do you see for the future to, help make things more equal for everyone, or to continue everyone's efforts and, yourself and all the other doctors in the other countries?
The introduction of a game changer, the CFTR modulators, is a inflection point that cannot be understated. Granted, you can have the best medication, but if you don't know how to perform your chest PT, be aware of your diet, having your vitamins or enzymes, you're wasting $200,000 a year. But with outside the price, what we see in low and middle income countries, that eventually they will have access to the FTR modulators, we hope. They need to be working with their patients now, because any loss of lung function, gastrointestinal growth, height, weight, good nutrition would not be recovered if that is already lost. If you have a very damaged lung and now you're able to take CFTR modulators, that will not regenerate your lung. There's a critical aspect of how do we prepare those patients the best that we can when hopefully CFTR modulator or gene therapy is available. The same thing happens when we didn't have COVID vaccines.
Mm-hmm.
You remember, we were completely shut down because until the vaccines were available, we need to be ready to prepare for the worst until we get that medication. If we didn't do that, it doesn't matter. You got the vaccine, you're already, you're bad.
That is a brilliant point, honestly, and something that the CF mom group, that I work with and the other parents that I talk to, that is one thing we talked about. If you don't have the vest, do the PFT. Like, there are other things that need to happen, and still 10%, possibly more, of the U.S. population doesn't have access to the CFTR modulators. So it isn't the complete answer for everyone because it won't help everyone. So it is important to do what you can, as I, heard you saying. That's a really important point. And more modulators are, of course, coming out. There's a lot of research being done. What do you say to families? Are you telling them basically what you just said, that you have to keep doing the basics so that you do have a chance?
Yes.
When and if better drugs become available to that population in Chile?
Yes. Until that medication, it happens to patients in the U.S. They were used to, for years, to a very strict regimen. CFTR modulators altered that regimen. It didn't eliminate that regimen. In some patients, that regimen, that new regimen, is very sustainable, very mild, light. In some others, it's not that light, and they will find out which one is their new regimen. If they don't have access to medication, have patients who have side effects to the medications, liver problems, they are off medication, what do? They need to go back to the previous regimen. Why? Because other medications are there. It's like, I don't have insulin this week. What do you need to do? Be very careful with my sugar intake. Families in countries where do not have, or they might have eventually, again, they need to be prepared. And once they become available, they will need to adjust with a proper medical team that is knowledgeable in making those changes in concordation with, complementing with the family. So what I see now is a word that we have been using in CF care, the co-production of care with the CFTR modulators that are aimed to your mutation, not my friend's mutation. My mutations are different than my friends who have CF2. That will alter. Personalized medicine will demand a much active and periodic communication with your care providers. You will be co-producing care all the time.
And I wanted to ask you this about publicity as far as what will help raise awareness. My thought is we need to all work together. We need to talk to pharma. We need to talk to insurance companies. We need to talk to everybody. I personally don't feel bashing any of them is helpful, but I do think they need to respond. But I wondered if you think I'm wrong. I mean, some people are bashing pharma. Some people are negative on pharma. It's just, I don't believe that is helpful. I think everybody has a part in it. I don't know any argument or any situation where everyone isn't in some way responsible. So that's kind of how I feel like the publicity and promotion and discussion should go. But I wondered what your thoughts are as far as raising awareness and publicity goes.
Pharma, as any industry, has a responsibility to their shareholders, and it's also fair to earn what you have invested. So you run the risk. And there's no question. And again, COVID-19 was a perfect example. The time frame to develop effective vaccinations were first time in the world that happened so quickly and effective. And so pharma has a great responsibility and opportunity to continue to work with us. We need to partner with them. we need to make them aware of the challenges that are created, what we call externalities. If you have a price that you're trying to recoup your investment, and that price is way outside, then it becomes a negative externality. And the externality might be absorbed in the US, but might not be absorbed or eliminated in other areas of the world. Make them aware of that situation by not just telling them they don't have it, but giving the explanation of why they don't have it. What are the barriers other than the price? That will probably help partnering with companies, with foundations. I mean, the CF Foundation is a big investor in the best sense of the world to get medications, new medications in to be available to patients. And raising awareness of the challenges when you are developing a strategy, how are you going to treat those patients? And a strategy that is present now is how do we treat patients with rare mutations?
Mm-hmm.
Well, rare mutations are more common outside the US because we're very homogeneous in mutations here. You go to Sweden or Norway, 80% of the population with CF, we have 508 homozygous. Very. So where do you find the rare mutation? In countries that do not have access. Are you going to use those patients as a test and not having those patients be rewarded or be, and not enjoying, but having access to that medication when it comes to the market? That's a challenge.
So it sounds like you agree that we all have to work together. I often tell people, we do need pharma. We need the insurance companies. If you push pharma out and they don't recoup their money, the rare disease population won't have medications because they won't be able to make money and continue their work. So that's one thing that I am very aware of and concerned about. So I think it is really important for all of us to work together. I had one last question, and then if there was anything else you wanted to add that we didn't talk about, please say it. But please talk about the CF Foundation's Global Advisory Committee that you're a part of, what that does in the world.
So I'm glad for the question. I think that's a great development at the CF Foundation. The CF Foundation is, without a doubt, the best equipped organization in CF care at any level, from science all the way to policy in the world. So the resources and expertise and gathering people with knowledge is second to none. Putting some of those resources into addressing, understanding the challenges of the families and teams have outside the U.S. is a very good development. Their mission and their commitment is to the U.S., but they are very generous in dispensing knowledge and supporting, sometimes financially. They have supported our pilot fully and making them get information that they can disperse to the other areas in the world. That is a very important work. It's very refreshing to see. I have been in CF care for over, close to 30 years now during my fellowship training. And the CF Foundation has evolved from being still very committed to the U.S. as it should be, but also expanding areas to understand better the challenge that people has outside the U.S. and trying to find solutions for that as well.
I saw all the brilliant people on it. It looks like it's a lot of doctors. Do you have parents on it?
Yes.
Okay, good, because I couldn't tell.
There are members of the family boards that from Europe and others that are also parents with CF.
Okay, great. Well, if ever you need another one, I am available. I would love it.
Okay.
Is there anything else that you wanted to talk about that maybe I didn't ask you about in all the work that you're doing?
Yeah, no, I don't have a question. I just want to have a comment of thanking you again for your interest in learning what we have been doing and learning a bit more how are the challenges in the area of the world that we work in CF. And my main objective is we are able to transfer knowledge to very capable people that have less resources. You see, we should learn how to tango, but Argentinians are the best in tango and in football, soccer too. So we can learn from them as well. There's a very easy, a straightforward manner to transfer knowledge with us. We are just community. We find new community elsewhere, and then we can transfer that knowledge very easily. You just need to be willing to do it and willing to accept. It's a two-way work.
It is. I mean, I think that is one of the greatest gifts we can give ourselves, is to learn from one another. I learn from people every day, and I always want to keep learning. So hopefully all your knowledge and everything you're working on, I know it's making a difference. And the more I learn, the more I want to do, and I know everyone else does too. So thanks for raising awareness about what you're doing and the people who need help all over the world. It's really important for all of us. At Education Day that I had a few weeks ago, CF parents weren't even aware that some other people with CF in other countries don't have access to medications. So we definitely have to keep spreading the word and raising awareness about it. But Dr. Gutierrez, thank you so much for your time. I appreciate all your knowledge and everything you're doing.
I appreciate it too. Thank you for having me today.
The original music in this podcast is performed by Kevin Allen.
It's not complicated.
Who happens to have cystic fibrosis.
We all got our worries and fears. I know it's got you frustrated, but loving you is so alright.
This has been the Living with Cystic Fibrosis podcast. For more information and to learn more about the Bonnell Foundation, visit our website at thebonnellfoundation.org. That's the BONNELL Foundation.org. This podcast was sponsored by Viatris, Genentech, and Vertex. It was produced by Jag and Detroit Podcasts. Follow our show on Apple Podcasts, Spotify, or wherever you're listening right now.